these are some of the things that we will be looking at today. And we're going to start off with, in the previous sessions, I mentioned about, like organizing microbiome and then knowing, your gram positives from your gram negatives and knowing what the treatments are for your gram positives and gram negatives, as well as knowing their virulence factors and how they will affect, what are the symptoms that you see when a person is affected. So today, for specifically for GI, you have secretory bacteria. The ones when they say secretory or non-inflammatory, that's like the bacteria that can cause vomiting, cause diarrhea, specifically diarrhea. So some of the bacteria are your, for instance, let's see, our gram-negative bacilli. And so our gram-negative bacilli, for instance, we have uh, s- in this, we're looking at, if it's ETEC, right? ETEC, that's known, that basically ETEC, EHEC, EPEC, right? They can give you a question based off of like, okay, water, drinking water, right? Where's like a traveler's diarrhea if they've been to like a different region or they've recently traveled and then they show signs of, um, diarrhea, that can one of the causes can be your ETEC and EHEC. And one of the key things that you have to know about that is that it's known for not basically doesn't ferment sorbitol, and it's a link to basically ground beef and other meats. Um, and then we have our um, Vibrio, right? So our Vibrio itself, um, oxidative positive, oxidative negatives, one way that you could just, specifically for your GI, gram negative, just being able to, and then also, knowing if it's secretory, non-secretory, and then what it does, right? What is it actually doing? What is a bacteria actually doing? What is it causing? We have that both of them are going to be activating our adenylyl cyclase, and then adenylyl cyclase, if we remember, that's part of our GS, right, pathway in terms of like the receptors. And so when we have an increase on our CAMP, that's going to lead to a loss of fluids, right, and electrolytes. And that's how, and we also know that that diarrhea, when a person vomits or has diarrhea, they're losing electrolytes and loss of fluids. And that could be because of them taking on or them, like being exposed or eating or drinking contaminated water and food. And one of the ways that you can combat ETEC specifically is by giving them fluids, right? You want to give people who have diarrhea or vomiting, you want to get them to have electrolyte and fluids. So um, next we have our viruses, right? So our viruses, you know, um, we're going to see this is going to be from okay, so for viruses, one thing that I didn't put over here, I should have put over here was basically if it's like a double-stranded, if it's RNA or if it's or DNA, right? DNA, single-stranded RNA. But for rotaviruses, one thing that we have to know about rotaviruses is that um, its route of transmission is fecal oral, right? So we'll mostly see that in kids. So like a vignette, you'll see a vignette, and like if it says like a kid, comes up sick, is diarrhea has like diarrhea or vomiting. That can be, like because of rotavirus, because they are known. You do have kids, especially like preschool kids or like going into, like in the playground, that could be like one of the causes for them being exposed to rotavirus or if they haven't been vaccinated. And so, right, um, and for our norovirus, right, again, you guys are going to be like learning about this. Um, it's again also fecal oral. So if it's fecal oral, that means that it's that it can be either, that it's from the transmission is from um, fecal, which is fecus, to oral, right? And so that can happen because like for whatever reason, but like you'll find that in contaminated water, in food, in like fruits that haven't been washed properly, or shellfish, and both of these are going to be causing damages to our enterocytes in the GI, right? So you'll have malabsorption, you're not able to absorb, your intestines aren't absorbing enough water and nutrients. However, the thing about this is that it is self-limiting, and it usually resolves within a week. And then you have your protozoans. So protozoans, you have your Giardia, which is protozoans are just like your basically, um, how do you say it? Like they are uh, like they are just single. They're, if I remember, they're like single-celled eukaryotic organisms. So some of like the characteristics that of like Giardia, like we are going to be seeing a picture of what Giardia looks like. So they have like an infective form, and then they have a non-infective form. So infective form is usually like a cyst. So right here we'll have like our cyst, and that can happen. And you can get those cysts from drinking water from contaminated streams. So usually, like a question with this, with Giardia specifically, it's like if you are traveling, right, or like in a river or something, and then you happen to drink water from a river, you can get these. And then so the cyst, their pathogenesis is, so yes, they spread through the water, and then they have a pathogenesis. The pathogenesis of the Giardia is that um, you had the infective form, which was the cyst just over here, and then you have the active form of the protozoa, right? So when they say trophozoites, that's the active form. So the active form is going to basically attach to the mucosa, right? Cause malabsorption, and then it's going to cause a blockage of bile ducts, and then that's going to be causing a flatulence, and then foul-smelling, frothy stools. Basically, it's going to be causing dysentery. Um, it's going to be causing you to have, like in a vignette, you're going to see a person coming with complaints of having foul-smelling stool. And the best way to like kind of like get rid, or like to reduce the infect, or to reduce exposure to Giardia cyst, is by boiling and filtering, your water. And then continuing on, we have our Cryptosporidium, our Cystospora, and then our Cyclospora. This route is also fecal oral. Again, when they say fecal oral, it's just mouth to butt to mouth, right? That's what they mean, because um so this one is mostly asymptomatic, but if patients are immunocompromised, so immunocompromised means that if they have like a weakened immune system, then they are going to be affected, more affected by these protozoans than, like those who have a stronger immune system. And the way that we would find out is that we would see oocysts in stool, right? But we would test, or that we would send their stool out to the lab, and then they would acid fast stain it. And those are just some of your secretory and non-inflammatory, right, diarrhea. And then next, we move on to our inflammatory diarrhea, or tissue evasion, right? And then that causes bloody, or scanty, with blood and mucus. So for that one, we're gonna have basically. mm, are you guys able to see my screen? I don't know why I blanked out. 1 second. Okay, so starting off with okay, so this one, gram-negative right here. So for our Shigella, right? We look at Shigella, we know it is gram-negative rod, right? And then all of this is basically telling us that the Shigella is NM, right? It's non, oh, thank you. Okay, so basically it's telling us that it's non-motile, right? And it's hydrogen sulfide negative. It infects humans, right? And has a low infectious dose, right? Meaning that you just need a low amount of it to be able to infect a human. And it's invading through the M cells in the gut, right? That's how it's invading. And basically, they are producing a toxin, which is called the Shiga toxin. And what the Shiga toxin itself is doing that is that it's it's breaking the 60S ribosome. And then so clinical symptoms are going to be showing us dysentery, right? Reactive arthritis, and then HUS. And then if we move on to our salmonella is the same thing. It's talking about M, right? M is like, it means motile, so it moves. You have bacteria that are non-motile, and then you have bacteria that are motile, right? That move around. So salmonella is one of them, and then we've heard about salmonella, right? It's basically, like from handling raw eggs or from handling chicken, right? And then salmonella is sulfide, hydrogen sulfide positive, and they are also invading through the M cells, and they can cause a bunch of different conditions that usually like range from like enterocolitis and can cause osteomyelitis as well as reactive arthritis. Moving on, we have our and our um, EHEC and our STEC. So STEC, basically what STEC means is, or stands for, is Shiga toxin producing E. coli, and then EHEC is just enterohemorrhagic E. coli, if I remember correctly. And this, you guys have to, I don't know if you guys can see my cursor. Hold on 1 second. Um, but okay, so this number, we have to know like this, the 015787, because they can ask you questions just based off of this alone. Like, so it is important to kind of know what this means, what this stands for. So, um, it's does not ferment sorbitol, right? So it's lactose fermenting, but it does not ferment sorbitol, and we can find it in ground beef as well as other meat products. And they produce a toxin that's a Shiga-like toxin, which is basically disrupting our protein synthesis, and then that's going to lead to hemorrhagic colitis and HUS. And then now we're moving on to our Campylobacter. So Campylobacter, what this is saying is that Campylobacter is a gull wing or a curved shaped bacteria that grows at a 42 degrees Celsius. Like we know that most bacteria cannot survive at or it's harder for them to survive at higher temperatures, but this one grows at 42 degrees Celsius, which is much higher than like the other bacteria can grow at. And it can cause enterocolitis, and then it can also lead to reactive arthritis, known as Guillain-Barré syndrome, which we are going to learn about. And it's also, again, mentioned, it can also be found in pets as well. I'm not sure which pets, but I know that it is also found in pets, unlike Pasteurella, which we know that Pasteurella can be found in dogs and cats. And Yersinia, Yersinia is non-motile. It also grows at 37 degrees. Is non-motile at 37 degrees, but it grows at 4 degrees Celsius. So that means that it can be found in at colder environments, and specifically on your meats and milk and so forth. And it's heat stable enterotoxin, and that can cause it can lead to a pseudoappendicitis or terminal ileocytis. And then next for our last on this is our gram-positive bacilli and our protozoas, right? So C. diff, it's a spore-forming anaerobe, right? And it's usually we can find it in uh, nosocomial infections. So the way that it colonizes is it colonizes through the mucosa and produces toxins, TCDA and B, and then that leads to a mucosal inflammation, and that leads to so a mucosal inflammation you have, and then you have damage to the pseudomembranous colitis. So buzzword that you will kind of like kind of or like a word, yeah, a buzzword that you kind of will see with this is something that will damage the pseudomembranous colitis because it's like very distinct amongst like other bacteria as to what it damages, especially just for like the GI module. So if you guys do see pseudomembranous colitis, that's just that's like one of like the buzzwords that you should be wary of. And then the way that you're going to basically treat it is antibiotic associated so, diarrhea and PMC. Right, PMC is just I'm sorry, no, the complications is going to be antibiotic associated diarrhea, and then PMC, which is same thing as pseudomembranous colitis. And then finally, we move on to our protozoas. Our protozoas, we have infective form. Remember, we have the infective form, and then we have a active form. So infective forms are usually cysts, and that's transferred because, to contaminate food and water. And then we have our trophozoites, which are the active form, and the trophozoites are going to be invading the mucosal, are going to invade the mucosal flask and cause flask-shaped ulcers, right? And the infection, the thing about this is that if it spreads, then the infections can spread to other sites, and that can be, like life-threatening, because if it goes to the brain and goes to the, the lungs, then it can cause abscess in there, and likely that uh, can occur. And okay, we'll move on to our next slide. And so this is talking about the bacteria that we can find that can cause food poisoning and intoxicosis, right? Vomiting and watery diarrhea. So we have our, excuse me, we have our gram-positive cocci and our gram-positive bacilli, right? Um, so for our gram-positive Staphylococcus, right? Staphylococcus itself, this bacteria, right? It's like one of the most common bacteria that we do find it normally in our flora. In human flora, this is a normal part of the human flora, and it can commonly found in salads, milk products, creams, so forth. It can produce a heat-stable enterotoxin, and this is basically one of its virulent factors, the factors that it has. And because of that, it can lead to symptoms like vomiting due to like the vagal stimulation, and it can cause increased intestinal peristalsis. So peristalsis is basically movement of the muscles in throughout the stomach, right? It'll cause like peristalsis, and then that can lead to fluid loss diarrhea. However, the incubation period for staph is 2 to 6 hours, and it's self-limiting. So if they ask you a question about a person, who has like increase in or who has like some type of pain but has been having diarrhea, and it's self-resolved, so most likely your agent is going to be Staphylococcus as well as it can be one of them can be um but as we see over here, like you can see for Bacillus, and then you can see for Clostridium perfringens, all of them are also self-resolving within 24 hours. But um notice how like for this one, for like they were to ask you like they'll ask you questions like salads would mostly be associated with staph, as opposed to rice, like refried rice. And like if you look at to differentiate look at how, like what was what was the source, and that can kind of like help you also differentiate, and then also knowing, what are the symptoms, because this is causing pain and loss of fluid, which is these two are just kind of like watery diarrhea as opposed to just, diarrhea as well over here, but no increase in intestinal peristalsis. So for our bacillus, again, this is found in rice and vegetables, and most likely the vignette that they will ask you is like, okay, a person has like, went to a restaurant, ordered probably some fried rice, right? Because you can get it by refry, like by recooking your rice, you can get Bacillus cereus, and it usually like will have a spore, and the spore can get like activated. So it does have a heat stable, right? When they say emetic, so it's just emetic is just like vagal. I mean, so it's emetic would be something that would cause vomiting, if I'm not mistaken. Um, it's just stimulating the vagus nerve, and then the heat labeled diarrheal toxin is going to affect your CAMP, right? So CAMP is part of um, it's part of our GS, right? Again, GS um, pathway. And then we're going to have an increase in CAMP. And then if we have an increase in CAMP, then that would lead to increase in the release of our calcium. And so more action, more stimulation occurs. And incubation is a little longer incubation, because they could just also ask you incubation periods. They can give you incubation periods. So if they ask you Bacillus has a longer incubation period than C. diff and Staph, but then uh, are but it has less than than Clostridium perfringens. And again, self-limiting, resolves within 24 hours. Now the next one is um, Clostridium perfringens, and that's going to be found in like our meats and curries, and it produces a heat label enterotoxin. That's just disrupting the transport in the ileum, and that can cause watery diarrhea, right? And incubation period again over here is 12 hours, less than 12 hours, but it usually resolves within 24 hours. Next, we have our Clostridium botulinum, and botulism is usually found in canned products, right? Can be found in canned products, and the toxin that this bacteria produces is called your BONT, right? Which is basically your botulinum neurotoxin. And the way that that's working is that it's blocking your acetylcholine release at the neuromuscular junction, and that can lead to paralysis, right? So you'll have like flaccid paralysis and like the face or your hands, and it is basically antitoxin and penicillin, right? You would need to antitoxin and penicillin you would need to use for it. And an infant, so yeah, there is another type of infant botulism. So only humans are hyperimmune serum. So infant botulism, how that occurs is if you give honey, right? If you're giving honey, that's why you're not supposed to give honey to kids under 1 year old, because they don't have the bacteria. Like they don't, their gut flora isn't um, fully developed yet. So Clostridium, they can just ingest Clostridium spores, which are found in the honey, and then that can lead to infant botulism, and infant botulism can lead to death, infant death. So it's like very careful. You have to be like very careful not to give your not to give honey to little kids. Okay. Okay, so next, this next slide that we have is just basically talking about, because you guys will be learning about like hepatitis, right? And hepatitis A's through yeah, A through E, I believe. But I think we learned all the hepatitis. Yes, we did. And so basically what this is showing is it just shows the different serological markers, right? And in the blood over time, right? So level of detection and when do we find it? So this is basically saying, like, for instance, for our hepatitis, this is our hepatitis B, right? The surface antigen. So SAG stands for surface antigen. So our surface antigen, it's going to appear early in the infection. So this graph is just showing when we have infection, when it's resolved. So early in the infection is when we're going to see early infection of HBV. And this marker, our HBE, is showing is a marker in general. This is a marker that shows high infectivity and active viral replication going on. So we see HAV, that means that we're seeing high infective um, and active viral replication going on. Next, we basically have um, our IgM antibody. This just means anti-HB. So this is just basically what it says is that it's an IgM antibody to hepatitis B core antigen. And this indicates if we see this, if we see the antibody, the anti-HB CB, this just indicates that we had a recent infection and is usually also present in an acute infection. Okay. And then next we have a anti-HBC, which is basically to antibody to IgG, which is IgGs. And if you guys recall IgG, or if I mean, I don't think you guys learned any of the immuno yet. So IgG is just basically a antibody that's found in the humans. You guys will be learning about like your antibodies in immuno. So basically what this is saying is that it remains, if we see this, then that's what it's showing right over here. I apologize, I didn't go for like your acute infection, right? High infectivity, low infectivity, right? Your window period, which is right here, because that's where you don't see anything over here, right? That's the window of period to find out. Kevin, if I'm not mistaken, is that what the window period is for? Or Alex?
Yeah, the window period, the way they tested us, remember like which period we would not see any antigens or antibodies, right? But yet the person still have hepatitis B. So we have to be aware there is such thing as window period, right? Right, where between 5 and 6. Um, and that's why it can be like false negative. But actually, patient does have hepatitis B.
Okay.
And they will
Yep.
give you this graph, right? And they will just ask you to show, uh, like basically like many questions can come from this graph.
All right. Thank you, Alex. Okay. So yeah, so knowing this chart is like very important as well. And knowing when we'll see what's present, right? What antibodies are present, what what antibodies are also present as well. Like if you know antibodies and or antigens, right? Antigens and antibodies, that's like um really important as well, right? It shows you because it's like this, you can determine this to figure out when a person's been affected, when a person is currently affected, as opposed to, and then one when a person has, like when a person is no longer affected. So for instance, like I was mentioning about this the Ig antibody to hepatitis B, that if we see this, and when do we see this? Over here, we can see over here, it's showing that we see this in the window period, right? And that it would indicate a chronic infection, and that it would also indicate a past infection or resolved infection. So we see these markers of pluses means that, yeah, that's where we would see it, and the negatives is that we don't see it, right? Um, so moving on to our antibody to HBE. And that's going to appear after our clearance of our HBE. So once this has cleared, that's when we are going to see this. So that means that now the infectivity has lowered, right? So it's because it's person to person, right? So that means that their rate of infecting someone else is much lower, as opposed to this high infectivity rate right here. So you notice all the antigens once it happens, it's all goes down, except yes, so all of them, these are except for anti-HBC, which is our antibody to the IgM antibody, which is the only one that would also indicate high infectivity. All the other ones are going to be showing more of a specifically antibody to antigen HBE, which would indicate definitely, like if you see this on your marker test, you would know that it's a low infectivity rate. And then lastly, we have our antibody to our hepatitis B surface antigen. And this, if we are to see this in a question, or if they give you a similar chart and they just show you this, this would show that we have, that we're basically in recovery and that we are immune to the HPV. And so again, if I haven't I'm just going to summarize it really quickly, like what all of this just means, just for clear understanding. This just means that if we see acute infection, high infectivity, this indicates that we have a new highly infectious state. Acute infections, low infectivity, means that only our HB surface antigen is positive, and there's a transition from anti-HBE present. So basically, it's just showing that we have a lower infectivity rate. Window period is basically a period, like we can see what in the window period what's present over here. So we can have basically an understanding that, okay, so this is basically showing us that our HB surface antigen has disappeared, but we don't see a surface antigen antibody here yet, you know. So that means that we're in the window period. It's like a good way to show us that, because they won't give you a window period, right? You would be able to, like, so to figure out the window period, you would have to see, okay, so I don't have the surface antigen anymore, and I don't have the HBe antigen anymore as well, but we do have indications of our antibodies over here, but there is no antibody for our HB surface antibody. So that would show us that it's in the window period. And then chronic infection, basically chronic infection, we would see if it's present beyond 6 months, right? But this one would vary because sometimes you could see, HBe antigen or not, and then also antibody or HBe antibody as well can be there and can not be there. And then basically our past infections. Oh, 1 second. Let me see if I could get my pointer. Is this better? Okay, you're welcome. Okay, so like I was saying, chronic infections are window of a period, and then our past infections. This is basically showing us that past resolved infection, right? All this is indicating to us is that the person has now cleared, right? Has cleared. We don't see any of the surface antigens, right? We do see some of our, now we see all of our antibodies. And then immunization is basically the only thing's going to be present in our immunization is going to be the HB surface antibodies. And if we see this, we don't see anything else, but we see this, that would indicate that, okay, the person has, or the person is vaccinated. And next, we are just basically, this is talking about our different types of hepatitis, right? A, B, C, D, and E, right? So this shows basically our short and our long, right? Incubation periods versus like onset of the bacterial. Then moving on, and then yeah, this is something that we should know basically. So symptoms of hepatitis. How do we know that a person has hepatitis? Right, we're going to see fatigue, right, loss of appetite, nausea, pain, fullness in the right upper quadrant, right, clay-colored stools, darkening of urine, and jaundice. And serological markers, like that's what's really helpful in helping us distinguish, okay, the difference between hepatitis A and B and so forth. But I believe for hepatitis D, we see hepatitis D more in pregnancy. And hepatitis D can only occur if you've had hepatitis B. Otherwise, you won't get hepatitis D. Is that right, Alex or Kevin?
Yes, 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 you got it. Yeah, I
Okay.
think you are the one actually who explained it to me. You said that if the person had hepatitis B in the past, then they can get hepatitis D. And that's why for pregnant women with history of hepatitis B, if they do get hepatitis D, right, that is very, very lethal, both for mom and a baby, because it causes like fulminant. I think it means like total, just destruction of the liver.
All right. Thank you,
Yeah,
Alex.
yeah, I think the hepatitis D
Mhm.
occurs only when you have the B co-infected or super-infected. So and that happens only in the pregnant woman. It's more the serious problem in pregnant woman, I guess. But hepatitis B, I mean D, cannot occur by itself. It has to be affected, either co-infected with B or super-infected. So co-infected means that B and D together, and then the super-infection is like the if you had a B, and then in addition to that, that occurs the T infections. Let me look it up to make it clear, okay? And then I'll reply in the chat.
Okay. Thank you so much, Kevin. Okay. And let's move on to our next. Okay. Now this is just a summarization, right, of all of our hepatitis. And over here, oh, 1 second, did I? Okay. So over here, knowing family morphology is like it's a must, right? You have to know single-stranded RNA, right, versus double-stranded RNA. Which ones are so the only ones from H. So the way to even approach it is like, okay, you have all your hepatitis, right? So which hepatitis? The only hepatitis that we see over here that's not single-stranded is our HBV, right? HBV is the only one that's double-stranded. All of them are coming from different families, right? But only one of them is double-stranded DNA, right? Partially enveloped. Um, and so, and then also most of them are enveloped except for A and E. So the first and last hepatitis, if you see a question stem, right, and you know that it's you know, if they mention that it's naked, right, then that would eliminate B, C, and D, right? Because then you know that only A and E are the only ones that can be naked. So naked, but knowing the family as well, Picorna viridae as opposed to Epiviridae. Transmission, naked means that transmission can be fecal oral, right? And naked viruses, are usually a lot stronger or a lot resistant, because they could survive in a lot harsher environment compared to enveloped, right? Um, Enveloped, which are not as I don't want to say they're like stronger, but like it's just you like they're more able to be more resistant to a lot of other things. Yes, this is a good chart to learn. Yes. Um, so these this chart that I have, this is like pretty good. But again, it's always good to look at the material that you guys are gonna get, but this pretty much sums up. If you want to review what's ahead, I really recommend, this chart. It sums it down really nicely, specifically for hepatitis. It does a great job of telling you what you need to know and how you can not miss out on any questions by just knowing this chart specifically for hepatitis. You should be good. Transmissions, right? So another thing is that's not over here, if I'm not mistaken, is they can ask you a question. The way that they can ask you this, if I remember, is through needles, right? It's either through sexual contact or through needles. And they can give you a question asking you that a person has traveled and gotten a tattoo, and then all of a sudden he has like symptoms of hepatitis. Right? They can ask you that too. So knowing also additional like just knowing other routes of infection is like helpful to kind of like just basically narrow down between the hepatitis. And over here, we're going to see the clinical features, right? Hepatitis A, acute viral hepatitis, right? Um, the treatment is that we use a vaccine for it, have care for it. Hepatitis B, which we just showed like the whole chart, which is like very important to know that graph, the one right here. Let me show you this. This chart is like so important to know. So like I highly recommend, um, trying to understand and trying to understand this, trying to know what occurs, trying to know the window period, specifically the window period, because it shows you what state, like we're at, and if they've been infected or if they're not infected. So I highly recommend you going over this. And for HPV, again, clinical features for this one, that it could be either acute, chronic, or fulminant, right? And most of it is going to occur in infants and children, right? It can cause liver injury it can cause liver injury, and it can also lead to cirrhosis as well, right? Um, Diagnosis, we're going to see the three antigens that I showed you, the surface antigen, the E antigen, so forth. And the way that you're going to treat it is if it's acute, it's supportive, right? And if it's chronic, then you use an alpha IFN, and then you use basically you're using antiviral vaccines for it and antiviral treatments for it, and then you're also going to be using a vaccine containing your HB surface antigen. And remember, this was like in the chart. This was one of the ways that we were able to figure out if the person has been immunized or not. Then next we have our hepatitis C, and that comes from our Flaviviridae Viridae family. It's single-stranded, right? Parental or sexual contact. Acute infections are usually asymptomatic, right? But 70% chance of leading to chronicity. So because it's asymptomatic, you can have it, but you won't be aware of it. And so that's why it can come and go and you won't be aware of it. So it's also the #1 infectious cause of chronic liver diseases and liver transplantation. So they can ask you a question, talking about like, oh, this person's been, like have like some problems with the liver or something like that, and asymptomatic, and so you should be able to like suspect or at least have an idea in your head that, okay, if it's asymptomatic and the person's not feeling it, but he's having, problems with his liver, could be because of your hepatitis C. So diagnosis that we're going to do is we're going to do like the Western blot, right? We're going to do a PCR, and then we're going to be using basically a pegylated IFN, and then Vibravirin, which is basically our antivirals, but there is no vaccines because it mutates. So it's kind of like the common cold, and the fact that we're the common cold, where we have to get different vaccines every year, because it changes. But however, for this, because the virus changes and mutates very frequently, there's no way of, like there's no readily available vaccine to give to the person. And then hepatitis D, right? So this is what like Kevin had mentioned, co-infection or superinfection with HPV. So you would need HPV, right? And need HPV in order to get this in order to get hepatitis D, and diagnosis would be that you would see hepatitis B surface antigen as well as an anti HDV hepatitis D antibody as well. And then again, these are the treatments for it. And then E, okay, so my mistake. E is for pregnant women. Yeah, hepatitis E is what we'll see in pregnant women. So that's also naked. The oral transmission, right? It's mild, has no, so like if they ask you a question about like a pregnant woman, like having, some like mild symptoms or whatever, like of like the symptoms of hepatitis, then you can suspect it to be HCV. And there's no treatment other than just supportive care um, for hepatitis E. Okay, so next, we just move on to so these are going to be our worms, or so-called our, other bugs that we're going to be that you guys are going to be learning about in GI itself. So the important things, just in general, the important things that we have to know about this is that how they look like, right? Because they can throw a picture at you, and they can just show you these pictures, just this, and then expect you to know that it's Ascaris lumbricoides, right? They just ask you what this is. I'm sure they will give you some type of, like the person comes in with some type of like pneumonitis or intestinal obstruction. They could show you that, but um, it's very important to memorize what they look like. They could be as simple. So, for instance, for Ascaris lumbricoides, right? It's usually ingested to contaminated hands, right? So a person can just have eating something from his hands and then get it from the food. And then so with our pathogenesis, which basically is telling us that the eggs that we now ingested, the eggs, right, are going to hatch in the small intestine, right? So then the larvae now they're going to go to the lungs, they're going to get coughed up, and then they're going to re-swallowed, right? Crazy, because they get carried to the lung, coughed up, and then swallowed, and then they they re-enter the intestine, and then they mature into an adult worm. And so our features, which this is showing, is that person can have, if it's like a kid, right? If it's a child, then they can have growth retardation, right? They can have pneumonitis, they have they can have like destruction of their intestines, and they could have liver damage as well as pancreatic damage. And then we would diagnose it by getting a stool sample, and we would see like these eggs. And the way to prevent this is avoid using human excrement as vegetable fertilizer. I don't know why they would use human excrement as vegetable fertilizers, but apparently they do use it, I guess. But yeah, guys, just remember, don't use human excrement for vegetable fertilizers. Anyways, moving on to another worm's Enterovermicularis. Know the picture. right? It's an embryonated eggs. The way that we can get this is basically we're going to be ingesting eggs or autoinfections. Again, this is the same thing from our hands, right? Mouth after scratching. And okay, so I think so the way that they wrote it is kind of like off, but basically this is like you see this occur more in like kids because they usually like scratch their butts or whatever, right? And then they like touch their face with it, or other kids like do that, and they touch their face with it, and then so because of like the fecal oral kind of like it's kind of also fecal oral route as well. And so when you have that, the way its pathogenesis happens is, or the way that it infects is that the female worm, right, is going to emerge, right? See right here, the perianal skin. So literally on the perianal skin of the anus, we are of the butt. We're going to see thousands of these eggs, right? And then these eggs are going to develop into infectious larvae within 6 hours, right? Clinical features are going to have like not being able to sleep, right? You're gonna have intense itching in the anal area, especially at night, and scratching predisposes right to the bacterial and infection itself, meaning that the more you're scratching, the worse it gets. So the way that they've actually found out a way to, or the way that they've discovered a way to diagnose of the eggs is by literally taking a scotch tape, a piece of scotch tape, and then placing it on that area, and then taking off the tape to see the eggs, and then this is the image that they will see. So buzzword for this is scotch tape, right? Because this is very unique in the way that it's diagnosed, and so highly recommend that like the buzz tape, the scotch tape. I think this is the only one that we will like you guys will learn that does have this method of the scotch tape method. And you want to the way that you can prevent it is obviously washing your hands, teaching the kids to wash their hands and not be like scratching the anal area too much or avoiding it, and obviously keeping your nails trim so you could prevent the spread. And then next we have our ankylostoma and our nectar armenicanus, right? Which is our flavy, it's our wait, am I reading? Filariform larvae. So the way that this works is that it's going to penetrate the skin of the feet. Usually what will happen is that you're walking in like a sandy area. Like for instance, like well, we have a lot of beaches, right? So it's just highly recommended not to walk barefooted in the sand, because there's a chance that you guys can, get a hold of this larvae, and then this larvae will literally penetrate through the feet, through underneath the feet, through the skin, and then can travel upward. So right here, it's penetrating the skin, right? So it's penetrating the skin, and then it's again carried up to the lung, coughed, and then swallowed. That's crazy. Like just like the way that it just coughs, goes with your lungs, and it's coughed up, then you swallow it, and then that matures, and then the adult worm, and then the adult worms, and basically the adult worms are feeding on the blood, right? And look like over here that the worms in general are sucking about 0.03 to 0.02 milliliters of blood every day, right? Features that we're going to see is ground age as such. So a person's going to come in and they're going to be like scratching their foot a lot. And also you are going to be able to see some like markations of the penetration, as well as some like shadowing of the larvae as well. And then you're going to have just basically these diagnoses, which is our abdominal pain, our person losing weight loss as well, if right, having a loss of weight because they are sucking in a lot of blood. And then anemia, right? A key factor thing in differentiating this is a person comes with anemia, hyperchromic anemia, and an iron deficiency because blood is being sucked up. So this is like another like kind of key thing to look out for, like key things to kind of light out. And then demonstration, again, we're going to be looking at the stool and we're going to be seeing this type of egg. So know the pictures and wear shoes while walking outside in the endemic area, right? Just it's always good to wear some type of either slippers or whatever, just to be on the safe side and not have a blood-sucking worm. So next is our strongylitis, and for all of these, I watched Sketchy. Honestly, like Sketchy, like really helped with micro in general, and it really helped with in general, just really helped with me memorizing and understanding microbiome. So I really recommend going over Sketchy, going over the Sketchy videos, and then going over the histo, because there you can just simply just give you the histo, know like the infective form and then the active form for some of them as well. And just having a structured organization really does help. So next we have our Stercoralis, which is basically a larva, same thing, right? It's going to be penetrating the feet, right? And again, this one's a little lighter, just know which is which, but the blood sucking thing only happens with your Nicator americanis or our duodenal, right? So know the name too, because they can ask you alternative names. So for this one, it's the larvae again. It's going to be penetrating through the feet, right, laying eggs, and then the larvae is gonna immediately hatch. And then, but for this one, we have asymptomatic infections, and then we're only going to see hyperinfection syndrome in those who are immunocompromised. So people who are immunocompromised, meaning their immune system is weakened, we are going to be seeing like they're going to be more affected and their infections are going to be more prevalent than those that have a much stronger immune system or normal immune system. And then the way that we diagnose it is that we're going to see active motile, meaning that moving, right? Actively motile rhabdidiform larvae in the stool. So this is what we're going to see. And again, wear shoes while walking outside in the endemic area. And excuse me, sorry. And then so next we have our worms, right? Our Trichinella spiralis and our Tinea solium and our Tinea, I'm sorry guys, our Tinea solium and our Tinea saginata, right? So these, we can see these or we'll see these. Question will usually ask you guys about like, okay, someone has like ingested undercooked meat or like pork or whatever it is, usually undercooked meat, and then but the undercooked meat has these encysted larvae. So the encysted larvae over here is I'm sorry guys, the encysted larvae right here, 1 second, where's my thing? Okay, so all right, so question will ask you, like I said, ask you about this. They have, but they've ingested something with a larvae, and this, right? These larvae is like something you got to know. Like again, histo. If you just know the histo, if you could just memorize the histo itself, like it will just like make things so much easier because they will ask you questions based off of just the histo, and kind of like it'll be just a first order question. What is it? Type of question. So pathogenesis for this is like it's going to be first going to ingest it, and then it's going to be right, it's going to be liberated or in the intestines, and then it's going to mature. And then when it mature, the female is going to give birth to the larvae, and then that's going to go into specifically into your muscles, right? So striated muscles. So for this one, this is very important if you know striated muscle, because diagnosis, the way that we're going to diagnose this is that we're going to see the larvae is going to be implicated in meat or muscle biopsy of the patient. So its features, we're going to see myocarditis is one important thing since it's going through the muscles. Myocarditis are very important. So we're also going to be seeing our splinters, right? Eosinophilia. Why? Because this is so I'm not sure if you guys have learned, but basically if you see high levels of eosinophils, they usually go after eosinophils usually go after your protozoas, right? They actually are in response to a lot of your protozoas. So we will see like a high level of eosinophils as well. And we're going to have edema, right? As well as psychosis, because this can go into your muscles, can go into the brain as well, meningoencephalitis. So you can have psychosis. And then the way to prevent this is to just properly cook your meat, right? Make sure that it's up to standard temperature, whatever they require for it, to make sure that you don't have any of these or don't ingest any of these worms. Then a next one is the Solium and our Saginata, right? Same thing, ingested with raw or undercooked beef or pork, right? They're hermaphrodite, so they can be either male or female, basically, and they are usually asymptomatic, right? But they can cause malnutrition, right? They'll call malnutrition because they're basically in the intestine, right? They can disrupt the intestine. So for this, we were going to be seeing like hyperactive reflexes and then visual defects, because also like they would be traveling, they could travel all around and then cause certain type of cranial nerve damage, right? So because they cause cranial nerve damage, that can also lead to visual defects as well as your reflexes, that I'm pretty sure you've learned about nerve. I'm not sure if you've learned about like nerve damage and in Med 1, but that can lead to hyperactive reflexes as well as visual defects. And for diagnosis, we're going to be so one of the things is that for most of the worms you'll see in the stools, right? Except for your enterovirus, which you're going to see on a scotch tape on the perianal region. Most of them, the diagnosis is going to be on the stool itself, and radiology. So again, know the pictures, because I do remember we had this one picture right here. They just gave this picture. You had to know it's spiralis, and then this picture as well. You had to know that's Solium. And then also avoid eating undercooked, raw, or beef, pork, whatever. Make sure that's properly cooked. And then moving on, these are our next two worms, and these same thing. Ingestion. This specifically is just saying that it's ingestion of undercooked, pickled or fresh water, undercooked or pickled fresh water, right? Pathogenesis, same concept. It's going to go into your intestines, it's going to mature, and then where it's going to compete with your vitamin B12. And key feature for this one is that because it's, remember, B12, right? So B12, if you have a deficiency in your B12, that can lead to you have microcytic anemia, and then you have macrocytic anemia as well. Megaloblastic anemia. So megaloblastic is usually your cobalt or your vitamin B12, and because we have vitamin B12, key feature for this, like they will just throw this vitamin B12, like throw some type of loss, has a worm, and then B12 deficiency. Way to answer this. And again, knowing the image is very key, right? Avoid, same thing, prevention over here, how to prevent it. Cook your foods. And I think, yeah, this is just a kind of a summary, but last of like what you're going to be going through is your granuloses, right? Same thing, ingestion, right? How it's ingested, right? Through contaminated water, right? Hand to mouth transmission of canine feces carrying. So this is interesting because basically this can happen in a farm, or it can happen in a farm setting, or this can happen in like a river or something, not a river, but like a little I remember reading something on this, basically like it's like if you have a lot of like dogs in your house, and like for instance you have like a pool or a swimming pool, and you are swimming with your dogs, like it's not recommended to swim with them, because you could get, technically you could, if your dog isn't like up to date with their immunization, there's a possibility of getting this from them. But again, this is called occupational disease in shepherds, butchers, and tanners. This looks like a coin. It literally looks like a coin. That's like one way to remember it. But the thing is, larvae are going to hatch in the intestine, same thing that is going to hatch, and then it's going to move through all along the tissues and so forth, right? And then in humans, it's they're accidental intermediate hosts because it's not really meant human to human. So they could just come in the crossfire. And again, these are just some of the clinical features that we're going to see, as well as what we would see on radiology and an ultrasound. And this is like the thing that we're going to see is like the cyst. Like we can actually see the cyst. So best thing to do is washing hands after handling dogs, right? And then avoid slaughter of sheep or livestock. And these are just a summary of like all the worms that you guys are going to be learning, right? And whipworm, right? They could ask you questions on a roundworm. They don't even have to say that. They just have to say a hookworm, pinworm, or a roundworm. So it's important to know what is what, right? What is a roundworm? What is a hookworm? And what's a pinworm? And they could literally just ask you questions on that. And then, so forth, knowing their more simpler terms or simple words, they could just ask you questions on that as well. So it's important to just know how to classify them, and then how to like just in their basic terminology as opposed to their full-on name. And that's my part for now. I'm going to do pharmacology later, but I'm going to hand it off to Alex for pathology.
Okay, thank you so much, Sunny. Let's just take like 3-minute break, all right, while I figure out how to project. Okay, can you please let me know if I'm audible?
Yes, you were.
Okay, perfect. Thank you. All right, so we will review quickly GI pathology right now. Just wanted to let you know, guys, that you will have a lot of time during Med 3 to master your hepatitis, right? And all the diseases. It might seem like a lot, but you really have like more than, like you have like few days, right? Versus few hours to master that all. So let's start with oral cavity. I just put like basic anatomy for you guys to refresh on. It's important to remember how our tongue is innervated, right? the cranial nerve 12, and then cranial nerve 9. But let me, I'm not going to confuse you right now. I'm just going to insert the slide here with the narration as well. Also, it's important to know the anatomy of salivary glands and tonsils, because there are a lot of diseases that you will have to distinguish that involve those glands, right? So just for overview, remember we have our parotid gland, right? The largest gland. Then we have our submandibular, and then sublingual. Of course, we have submental and others like postauricular and stuff like that, but you do need to know those for ICM. The pathology mainly involves those 3 glands. On the right side, you see some diseases, right, or disorders that you will see for oral pathology. Your basic ulcers, right, or canker sores. You do need to know what is the association with what are they associated with, right? Celiac disease, inflammatory, and so on. Squamous cell carcinoma. Remember, cancer will be a huge thing in Mat3, right? So you will be distinguishing the histology of squamous cell carcinoma, and associations are very important. HPV-16 and tobacco smoking. You do need to know the precursor lesions, right? So like white patch versus red patch and so on. Also stones in major salivary glands, right? You probably also would need to see the histology on that. Inflammation due to the obstruction, and some salivary gland tumors. So those tumors that are listed here are the ones that we will be most likely tested on. Okay, this is just the overview of the microbiology, right? And you guys already did that, but those are some microorganisms that can cause problems in the facial and oral area. All right, for esophagus, moving down, right, our GI tract. Esophagus, just a refresher for you, the basic anatomy. Remember, we have upper esophageal sphincter and then the lower one. And then you guys remember they have different composition in terms of the muscles. The histology, just make sure you know how to distinguish between mucosa, right, submucosa, muscularis externa, and adventitia, of course, because there are certain diseases that will involve the thickening of one layer versus the other. Okay, this refers just to the pathology, right? Dysphagia, they call it, swallowing pathology. So achalasia, you will see this famous sort of like a picture of a bird beak, if you see it over here, bird beak appearance, right? And what happens, you give a patient barium swallow and it just gets stuck over here, right? Because there is a stenosis. And that can happen due to the damage in your neural cells, right? In ganglion cells. That's why the lower sphincter of esophagus is not able to be to relax. And that's why you have this constant constriction. You do need to know the mediators that are involved. Basically, because we have atrophy on those neurons, right? We don't have nitric oxides, and you know that nitric oxide is a vasodilator or dilator in general, right? And also we have decreased production of VIP. Sclerodermal, remember we talked yesterday about the skin pathology that involves the CRAS syndrome, right? So this is one of the symptoms. You will see sclerodermal esophageal dysmotility, basically because we have a lot of collagen deposited in the esophagus. Okay, distal, pretty self-explanatory, right? This is the buzzword for the distal esophageal spasm, corkscrew appearance. You will learn how to treat the each presentation, right? Esophageal webs are high yield. You will learn about them not only in GI, but also in HML because it involves Plummer. It's a part of Plummer-Vinson syndrome, which involves anemia, esophageal web, and beef red tongue. Okay, so you will see that syndrome in both modules. Now for diverticula, we have our Zenker. Diverticulum is basically outpouching of Killian's triangle. And for that, you guys will draw out your basically anatomy, right? And you will locate this triangle and you will know exactly where esophagus will be outpouching from. All right, so you will see the anatomical structure at the lecture. Yeah, and like epidemiology is a good thing to remember, but what I've noticed, they always switch it up on you. Like, for example, if my notes always like say younger male, right? And for some reason on the cast, they would put like postmenopausal woman. And like if your brain only kind of works with the buzzwords younger male, you might reject that answer, right, for some reason. So epidemiology, I think it would be more important for like clinicals or for an actual practice, right? But some diseases, of course, epidemiology can be a buzzword as well. All right, for esophageal pathologies, just wanted to kind of put it all together. It's a lot of them, some of them high yield, some of them kind of like on the lower spectrum. You will learn about the GERD, right? How to treat the GERD, what are the complications of GERD, which is the Barrett esophagus, right? And we know that the Barrett esophagus would be a precancerous lesion. Then esophagitis, right? You will learn it can happen due to the reflux, secondary to GERD, medication-induced, some autoimmune process, infectious, such as Candida. You will need to differentiate between Candida infection, HSV, and CMV. Basically, it's very simple. They will give you like 3 pictures. HSV would have like just ulcers, right? Like just vesicles. CMV would have linear, and then Candida would have like those white plaques. Mallory-Weiss syndrome. Basically, those are your tears, and usually they would give you in the vignette a person with an extensive alcohol consumption history, right? Or bulimia nervosa, right? Because when the patient self-induces vomiting, that puts a lot of pressure on the esophagus. All right, and then esophageal perforation would be a complication of Mallory-Weiss syndrome, or it can happen secondary to some trauma. So this is the picture of Mallory-Weiss syndrome. Those are your varices. Some call them alcoholic varices, right? Because very prominent in patients with alcohol abuse, and especially if they already have liver cirrhosis. Dr. Eli probably will show you this picture. Well, not this exact, but this picture of perforation of the esophagus, right? And then you will have this widened mediastinum. Okay. Okay, this is just to recap on the tears. So Mallory-Weiss tears. Associated, we already reviewed that. And then the complication would be a rupture. They call it Boerhaave or Boerhaave syndrome. All right. High yield would be leakage on the gastrograph and esophagram. Basically, whenever they swallow barium, it's gonna leak out in our mediastinum. Okay, it is a medical emergency. So it's important to quickly address that. Okay, I'm sorry about that. I'm back. Okay, again, the cancers, right? The precancerous lesions of esophagus would be Barrett's esophagus. Basically, you will learn how squamous epithelium gets undergoes metaplasia, right? And we have now non-ciliated columnar epithelium. Why? Because the esophagus tries to protect itself from the acid. However, it comes with the cost, right? We have a higher risk for cancer, especially adenocarcinoma. Squamous cell. Okay, so adenocarcinoma, also high yield, that would involve lower third of the esophagus. You will learn how the dysphagia, right? Remember that dysphagia is difficulty of swallowing, will progress slowly. First, patient would not be able to swallow solids, and eventually even liquids would be hard to swallow. Okay, and then apple core, of course, you will go over that on with the radiology lecture. All right, squamous cell carcinoma. Now we're talking about the upper two-thirds of the esophagus, remember? And that's why it's really important to know the normal anatomy and histology of esophagus and like GI tract in general. Okay, if we're talking about squamous cell carcinoma, you guys already know that it's synonymous with keratin pearls, right? So whenever you see this pearl, think about squamous cell carcinoma. And they said like some certain cultures, especially like Iranian cultures, for some reason, they have higher chances of squamous carcinoma of esophagus because they do drink hot tea. Okay, moving on to gastritis and peptic ulcers. Basically, we have two types of gastritis. We have acute and chronic. Acute can be caused by certain medications, by stress. So be careful, guys, whenever, like, especially right now, like don't drink coffee on an empty stomach, right? Always like take your medications with like full glass of water. Chronic gastritis, again, this is the persistent irritation, right? We're probably talking more, it depends on the physiology of like a person, but usually I think what, like 3 to 6 months, that would be already chronic gastritis, right? It can happen due to multiple reasons, autoimmune or H. pylori. You will need to distinguish by the location, right? So your antrum, you think about H. pylori infection. Your body infundus, you think it's some sort of autoimmune process. And high yield to know that gastritis, the chronic gastritis, has a higher risk of developing lymphoma, Mount lymphoma. This stands for something mucosal lymphoma. Okay, as I said earlier, you do need to know the locations of the ulcers because they will give you a clue which pathogen is responsible or what process is responsible for the formation of the ulcers. You will learn how to treat it, right? We have triple therapy. So remember our penicillin, right? Clarithromycin. Remember I said thromycin. It means belongs to the class of macrolides, and PPIs. PPIs, it's something like Protonix we use for acid reflux, and we will go over the farm a little bit later. So yeah, or they use triple therapy versus quadruple therapy. So basically over here, they will just add tetracycline and metronidazole and bismuth. Bismuth is your basically peptobasmo, I think. Okay, remember we talked about the production of arachidonic acid and how NSAIDs block the production of prostaglandins. Okay, high yield to note your curling and Cushing ulcers, right? Curling would happen from severe burns. Cushing ulcers would happen from injury of the brain injury. Okay, and just your like pathophysiology is explained over here. Okay, and another way to distinguish ulcers, if the pain worsens with meals, or pain might subside with meals. Okay, so that might give you like a clue. Either is that a duodenal ulcer, or are we talking about the gastric ulcer? And remember, that's again Med1, knowing what mediators are involved in your digestive process, right? So you see in ulcers in duodenum, they will improve with meals. Why? Because we have bicarb, right? Basically, bicarb will be excreted in duodenum, and this will neutralize acid. And in gastric ulcers, there's a lot of acid production. We're going to have a lot of pain. Okay, I meant to put that at the beginning just to review the stomach anatomy, just for your information. But again, this will be very important to know where is the fundus, right? Body, how's our duodenum connecting to the stomach, and so on. Stomach histology also very important. Just review whenever you have a chance all those cells and what do they produce. I think that's a pretty good picture. Okay, this is just the recap for gastritis from first aid. For peptic ulcers, yeah, just a summary, like how to distinguish between stomach ulcers and duodenal ulcers. Then we have complications of ulcers. Basically, it's a rupture, right? So we're going to have a hemorrhage, obstruction, or, okay, so if that's a tear, we're going to have like hemorrhage and perforation. We're going to have like of course, a lot of hemorrhage, and everything else. We're not going to have any motility as well. Also, remember how to distinguish upper GI bleed from the lower GI bleed. Remember, upper GI bleed most likely will present with like black color stool called melena, right? Because the blood is digested, and the lower GI bleed would present with a frank red blood. Okay, for GERD, I mean, I know we talked about it in esophagus. Just remember GERD, pretty common in the United States, so probably will be very tested on GERD. 1 second. Yeah. So we already talked about the GERD and esophagus. Meningeal disease, all you need to know that is basically what happens that one type of cells, foveolar cell, undergoes hyperplasia, right? And we have overproduction of gastric mucus. Because we have a lot of gastric mucus, we will have like parietal cells no longer would be needed, right? So they would undergo atrophy. We're going to have less acid. And because we need acid to break down protein, we're going to lose a lot of protein, right? And the patient will present with edema. Or you can remember it as WAVE. Those are symptoms such as weight loss, anorexia, vomiting, epigastric pain, and edema. All mnemonics from the first state. Some of them actually, what is another source that gives you mnemonic? I think it's RX or something like that. Yeah. For malignant gastric pathology, you need to know the adenocarcinoma, right? What do they present with? You will learn about the Sister Mary Joseph nodule and Virchow nodule. Know them very well for your ICM especially. Just the warning, like this Med 3 semester ICM will be very different. You will be expected a lot more than you were expected in Med 1 or Med 2. So just do extra reading before you go into the classes, all right? Mild lymphoma. Then we have another stromal tumors, which is GIST. All right, and you will learn all the markers such as c-KIT and like other key risk factors for all of those pathologies. Remember, in the skin section, we talked about those acanthoses, right? Actually, keratosis. And this is what I was talking about, the lesser trilacine, right? Basically, if we have a lot of them happening, like appearing all of a sudden, that's not just a skin problem, that's also a sign of underlying GI cancer, specifically adenocarcinoma. Moving on to liver histology. Review the liver histology because it's going to be very, very important. And if you already have it down, you don't have to worry about like memorizing all of this. Just remember we have 3 zones, right? Starting from like portal triad, moving to the central vein, right? And remember the zone 1 would be like a periportal zone. And then zone 2 would be in the middle, and zone 3 the one that surrounds the central vein. And zone 3 is very, very vulnerable zone because we already have less oxygenated blood coming right this way. And if, for example, some pathological process would happen that would require increased oxygen consumption, zone 3 would be the first zone that undergoes like injury adaptations or like ischemia. Yeah, I mean, they will probably like familiarize yourself with like your pathology book and their histology pictures. They might use them. I don't know if they're going to be like clear as this one. Okay, so for bilirubin, just remember the bilirubin, how was it produced, right? Remember we have our heme breakdown, and then we have unconjugated bilirubin. Okay, so I'm sorry about that. I'm back. So we have our unconjugated bilirubin, then it gets transported to the liver, where it undergoes conjugation, right? So this pathway is very, very important for you guys to review because a lot of disorders can happen anywhere along that pathway, bilirubin pathway. All right. And if you are the type who just learns by videos, just find something like very short, like 2-3 minute video, just that shows you animated bilirubin production. Okay, you will learn about all of those diseases: Gilbert, Crigler-Najjar, Dubin-Johnson, Rotor. And for the way you know which part of liver or what process kind of like in front of you, right? What pathology, they use liver enzymes as markers. For example, remember our aspartate aminotransferase versus alanine aminotransferase, so like your basic liver enzymes, right? The ratios would be very, very important. For example, if it's an alcoholic liver disease, you will know that AST would be elevated so much more than ALT. They both will be elevated, but just the degree of it. What else? Okay, you will have to know GGT elevated in the biliary diseases, right? If we talk about like a low albumin, no, it's like advanced liver diseases, right? The liver is not able to produce any proteins. If we have bleeding, like high prothrombin time, clotting factors are not able being produced by liver. Again, think liver pathology, right? And platelets. And this is just like a summary of some of the liver enzymes in different diseases. Okay, so for cirrhosis and portal hypertension, again, you will probably, okay, there is some overlap with hematology as well, such as Budd-Chiari syndrome. Yeah, just know that cirrhosis is basically a process that is characterized by this fibrous tissue. And I think I have another slide for that. Viral hepatitis. Okay, so Sani already talked about hepatitis A and B. This is just for your information. How would hepatitis B liver would look like right on liver biopsy? They use buzzword ground glass, and you will learn which drug to use for hepatitis B. For hepatitis C, so they say it's associated with transfusions and IV drug use. So if the patient had a remote history of blood transfusion, right, like somewhere in 1990s and before that, that's where blood was not tested for hepatitis B. So a lot of people who got blood transfusion in that but like in that time, they might most likely, not most likely, but there is a chance that they have hepatitis C. And high yield to know that hepatitis C is associated with carcinoma of the liver. Okay, also you will learn about the management for hepatitis C. Again, we said that hepatitis B and D go together because hepatitis D is not able to become infectious, right, without hepatitis B. Hepatitis E, also need to know. So we reviewed that already. This is just a picture for, again, because hepatitis B would be probably like higher up on the list of all the hepatitis, just because it is something that can be prevented, right? And it's something that, if not prevented, and unfortunately the person has it, causes a lot of complications. All right, so you will need to know that in and out, but don't worry, you will have like some time. You will review that during the SGA, and you will have, of course, like lecture or two on hepatitis B. Okay, another aspect of liver disease would be alcohol. Right, so for alcohol, basically you need to remember we're going to have a lot of fatty changes in the liver, right? They can be reversible. You will need to know how the lipids accumulate in the case of alcoholic hepatitis. We already talked about all those enzymes. And another hepatitis, which is called NASH, or non-alcoholic hepatic steatosis. It's also fatty liver disease, because the umbrella term for those would be fatty liver diseases, right? This is basically associated with obesity or some metabolic syndromes, and we have like your basic fat accumulation in liver. Okay, and now you see ALT and AST, they both elevated. Whether in alcoholic, right, fatty disease, AST is markedly elevated. And I think they like teach you in first aid, AST, think S for Scotch, meaning that AST would be elevated in alcoholics. Okay, cirrhosis, I already showed you that. This is the pathophysiology of cirrhosis. You will learn that, and you will be asked, how is it happening, right? Basically, your what is involved, TGF-beta, fibrosis, nodular scarring. And then why in cirrhosis, male would develop gynecomastia, right? Because liver is no longer able to produce a lot of proteins. So our sex hormone binding globulin would basically, hold on 1 second. Okay, so we would have, remember that liver also deals with estrogen, right? Metabolizes estrogen. But if it's not working well, it's not going to be able to metabolize estrogen. And then the binding globulins basically would decrease the testosterone, and the male with cirrhosis would present with gynecomastia and all of other, presentations. Okay, this is the picture. So this is the cirrhotic liver. All right. Okay, so you will learn how to manage the cirrhosis. Yeah, I think that's pretty much it for cirrhosis. Don't worry, you will have enough time to just kind of like familiarize yourself during the lectures. They will show you this histology, what stain do they use for the histology, right, for the liver diseases. Also, we have another disease such as drug-induced hepatic pathology. For example, it might be Reye syndrome. You will learn that especially children with Kawasaki disease cannot take aspirin because they will have this complication, Reye syndrome. All right. Or Tylenol toxicity, because remember, you're not allowed, like they say, do not take more than 4 grams of Tylenol a day, right, in 24 hours. And this one, okay. So this pathway we learned in Med 1, basically how glutathione is being produced, okay? You can look at it, or you will just kind of like refresh because I kind of like forgot about the glutathione pathway, but it is so like easy to understand. So you will refresh on that from Med 1. But basically, this is the basis of why Tylenol is so toxic to the liver in high doses, because it basically depletes the glutathione. You will need to know which drugs are hepatotoxic, right? And remember, we said that some resources might give you one list, right? But focus on what would be especially covered in the lectures. Okay, malignancy of liver, high yield, right? You will learn about the HCC, hepatocellular carcinoma. You will learn about angiosarcoma and you know that liver is the most common site for all metastases, right? For majority of metastases. So they will probably show you some radiology slides, right, for liver metastasis. You will learn all of those diseases, hemochromatosis, Wilson's, alpha-1 antitrypsin deficiency. This is the micro part of the liver injury. Okay. Benign tumors also, you will learn about benign tumors of the liver, and it's only like, what, 3 or 4 of them, right? The cavernous hemangioma, because it's hemangioma, you know, some blood vessels are involved, right? You need to know that biopsy is contraindicated because they're going to bleed, right? They have a lot of like those blood vessels or venous malformations. Liver is going to bleed. Then we have hepatic adenoma. Okay, for some reason, hepatic adenoma develops during the pregnancy or in especially in women who were taking oral contraceptives before. FNH, you will also learn focal nodular hyperplasia, right? It's probably one of the cases where the epidemiology would be helpful. It's young women with some liver diseases. You think about FNH. Okay. And remember, I told you that you will learn about like deposition diseases, right? So, for example, in Wilson diseases, there is a mutation in this chromosome 13 ATP7B gene. There are like a lot of mnemonics that you guys can use to remember. And basically, what happens? Copper accumulates in the brain and in the liver. Okay, you need to know how to treat that. And also Menkes disease, we're also gonna overview, you're also gonna overview the mutations, the genes, the pathophysiology, and what is the, like, what are they at risk for, those patients, right? In this case, that would be cerebral aneurysms. Those pictures will give you a clue. Okay, we're talking about the copper deposits over here, right? And so on. Genetic hepatic disorders. I think it's a continuation actually. This is the hemochromatosis. So remember, you will need to know whether it's autosomal recessive and which gene is involved, right? On what chromosome. Again, first aid or maybe sketchy, right? Just to remember. But honestly, I think you will just memorize it eventually before the exam. Okay, for hemochromatosis, it's important to see those values. What would be high? Remember how Kevin yesterday described what is ferritin, right? What is the binding capacity? What is transferrin, right? So, for example, if you see this value, you would be thinking about chemochromatosis, right? Okay, they actually call it bronze diabetes. Another word for chemochromatosis, bronze diabetes. Okay, then alpha antitrypsin deficiency. This one is high yield both for GI and for respiratory. So you will like basically know how it presents in the liver. I think this one you will already learn in the hematology section, right? The production of hemoglobin and so on. So that would, you see how it will be very helpful later in GI section. Okay, pancreas is a big thing as well. In Med3, you will not be focusing on diabetes, but only diseases of exocrine pancreas, right? So we have acute pancreatitis, right? You will need to know the blood, basically your blood work, right? The amylase or lipases will be elevated 3 times, right? Epigastric pain radiating to the back. And then it's going to worsen after the meals. They will get some relief if they're going to lean forward. All right. So that's acute pancreatitis. And then you will have to distinguish that. And you see, like on the radiology, this is your pancreas. You see how swollen it is. Again, just because you need to know how the normal looks like, I'm able to tell that it is swollen. But first look at the normal radiology. I think we can have the free access to Radiopedia or something like that if you put Antigua as the country of origin. I think they give free access for that. Then chronic pancreatitis. You see in this case, pancreas looks different, right? Yeah, pretty much you will learn about chronic pancreatitis. Again, it's a lot of some high yield and some low yield diseases that I have on this PowerPoint. What about the malignancies? Pancreatic adenocarcinoma, high yield. You will need to know the markers, right? It's CA19-9. All right. Again, this is the, you see the tumor at the head of the pancreas, right? Okay, gallstones. Basically, they will tell you, okay, so this is this presentation and you see the stone, right? What happens if we turn patient over, right? And this stone will be like, for example, here, you know that this is not a tumor, this can roll, so that's a stone, right? And then, of course, they always use this mnemonic for Fs, right? If it's obese female, fertile, around 40, high complaints of some abdominal pain that radiates to the back, think about the gallstones, right? Then you need to know different gallstones. How do they differ by color? Black, brown, right? And you see that black, they mostly happen from hemolysis, meaning that the people with some hemolytic pathologies would be at high risk for gallstones, and those gallstones will be black in color. Brown gallstones mostly come from infections. Yeah. Okay, so I think you already learned about the Murphy sign, right? Basically, when you press under the liver, and if it's a pain, it's a positive sign for gallstones or cholecystitis, actually. Okay, benign biliary disorders, also important in terms of histology and radiology. All right. Yeah, like everything is kind of like important on this slide, so I'm not going to overwhelm you. Again, you will have enough time to, digest everything. Just letting you know that most likely they're going to start with some functional diseases, will progress to some autoimmune, genetic, then infectious, and then this organ will always have some sort of tumors, either benign or malignant tumors. Okay, so this is the sequence, like how you will learn the pathology. Malignant biliary disorders. Porcelain gallbladder, high yield on radiology. It's not here, but you will have it in your lectures. You will learn about the Courvoisier sign. Basically, if you have this Courvoisier sign, right, it's not basically gallbladder will be enlarged, but it's not painful. Think about malignancy. And you will learn like the kind of like that if it's not painless, not movable, it's most likely cancer, not only in terms of GI, but in other systems as well. Why? Because it's not painful, there is no inflammation, right? There is other pathological process, and it's not movable because it's already eroded, right, down below the basement membrane. Okay, jaundice, you will learn the mechanism behind the jaundice, right? And that's the same picture for bilirubin production. So you will need to distinguish between conjugated jaundice and unconjugated, just because, remember I told you, anywhere along that pathway of bilirubin production, different pathologies can happen. If pathology is here, then we have a lot of unconjugated bilirubin, right? If the pathology will happen here, then the blood work will show conjugated bilirubin, and so on. And remember the syndromes that I already mentioned. Okay, this is just a physiology for intestines. You can review that when you have a chance, how the glucose gets digested, right? How the proteins and fats. This is the histology for large intestine, for small intestine. It will be, again, very important in cancers and so on. Okay, celiac diseases. Celiac disease is basically you will have a patient who is not able to, or have like a high flatulence, right? Production of gas after he eats or she eats like a bread or grains, and they will give you all of those presentation, right? Bloating in children, failure to thrive because they're not able to digest food properly, right? And yeah, then you will just learn how they recommend to treat it. Remember, we talked about in skin pathology how one of the presentation can be a sign of underlying celiac disease. Okay, lactose intolerance also. You will learn how lactose intolerance develops, or the patient already born with it, right? Because they say like majority of people, they lose tolerance for lactose as we age. Okay, okay, IBS and IBD would be very important, right? Those are very like different diseases. This is just a syndrome, right? And they think the syndrome is more mental, right? Basically, there is like a theory that it's a gut-brain axis disorder, right? And so it's a lot of patients will also have a presentation of anxiety, of depression, and so on. For IBD, I think I have different slides for that later. Okay, you need to know interoception. This is basically when one segment of basically like the intestine kind of like folds right inside. So it was like this, and then like this part just folds inside. And yeah, you just it's usually in infants, of course, right? When the baby is born, you will see current jelly stools, buzzword. Yeah, so you will learn that. Again, cancer, so the intestines, high yield. Let me see what I can tell you here. Yeah, I feel like this whole slide would be important because it specifically talks about the carcinoid tumors. And remember that carcinoid tumors, you always think about the serotonin syndrome. All right. Okay, so I think we can move on from here. Okay, Zollinger-Ellison syndrome. This is another syndrome that can, you know, be indicative of a tumor, right? Neuroendocrine tumors. And basically what's happening here, you have a high production of secretin and high production of gastrin. So patient would have a lot of ulcers, not only in the stomach, but like in distal areas, like in duodenum and even jejunum, right? And it's not supposed to be happening over there. As you remember from basic physiology, in duodenum we have high bicarb, but in this case we have so much of the gastrin produced that the bicarb is not able to neutralize all of this acid. Right, for small bowel obstructions, basically you will have those bubble signs. You will know this is a small bowel obstruction. Appendicitis, McBurney point, your ICM, right, knowledge. Okay. Okay, this is what I was talking about earlier for IBD, inflammatory bowel diseases. So we have two kinds, ulcerative colitis and the Crohn's disease. For UC, you will need to know the histology. You will need to know the radiology presentation. I think they call it, I forgot the exact word, but you will probably find, I mean, you will definitely learn that sign in radiology, okay? You need to know what ulcerative colitis is associated with what diseases. Management, also important. Now for Crohn's disease, okay, this sign they call comb, like, you know, the hair comb, the hair comb sign, you will know that it's a Crohn's disease. Yeah, or they call it like knife-like fissures here. Cobblestone mucosa for histology. Okay, and the location. This is how you will be able to distinguish between ulcerative colitis and Crohn's disease, not only by radiology, but also by location, because terminal ileum is and rectum. Terminal ileum would be most common for Crohn's diseases, when rectum and stomach would be most likely spared. Some neonatal disorders that you guys already learned, right? The Hirschsprung disease in neuro section. Okay, necrotizing enterocolitis. Basically, this is formula fed infants. And they're not able to digest it properly because remember, the gut is almost sterile, right, of the newborn. Meckel's diverticulum. I feel like we learned that in embryology already in Med 1. So just no rule of two for Meckel's diverticulum. Remember, like there is like an outpouching in the umbilicus. So it's like in 2% of the population, 2 inches long, 2 feet from the ileocecal valve, 2 times more common in males, first 2 years in life, and it contains 2 tissues, gastric and pancreatic. Okay, diverticulosis and angiodysplasia. Like small little topics that you guys need to know. Mesenteric ischemia. Again, emergency, right? So they will probably show you like radiology slides. Colonic polyps. They will give you like different kinds of polyps because you see like this one looks like it one not pedunculated, right? And those they like all separated. Or for example, this looks totally different. So you will basically learn different types of polyps. Probably like 1 or 2 questions can be asked in this section. Okay, colorectal cancer is a big topic. You will learn all of this. Yeah, this is, they call it apple core sign, right? This is the sign of the cancer. Of course, you need to know all of this. Like all this pathway is high yield. And yeah, also some polyposis. You will learn about the FAP, right? The familial adenomatous polyposis. You will learn about the Lynch syndrome. The thing about those syndromes, you do need to know all of the markers, tumor markers that are involved. Okay, and what is involved, like what genes, is that a loss of function or gain of function, and so on. And there are a lot of mnemonics in first aid you can use. For example, this one says take 11, right? And 11 means it most commonly in like children, right? Around like 10, 11 years old. Okay, juvenile polyposis. Yeah, you will learn all of that. And I think pretty much like this is overcap of all the diseases. And if Sunny wants to take over for the farm, also I included in my PowerPoint all the drugs for different diseases here. And just at the end, summary from the first aid.
Okay, perfect. Thank you. Let me just put up the farm. Give me 1 second. Let's take like a 3-minute, 2-minute break. In like 1 more minute, guys. Are you guys able to see my screen?
Yes.
Yes.
Okay. All right. So these are the drugs for the amoebas or the protozoas that I've listed before. So we're now just going to be going over the form section. So treatment, the drug treatment choices are usually your chloroquines, your metronidazoles, tinazoles, right? These are basically like the organisms that are acting on the bowel wall, and since most of the organisms discussed are acting on in the GI system, so this is like some of the options that you have in order to treat um, your protozoans, right? So you have your tissue amoebicides and then your luminal amoebicides. So basically, you guys will learn that in order to how to treat them and or how to use supportive care as well as treatment to help lower or get rid of the infection. Okay, and then over here, I just have the disease, right? For specifically for amoebiasis. So these are the drug of choices that we're going to use, and then the alternatives that we can use, as well as the disease form, right? So if these specifically for amoebiasis, which are just the earlier ones that we've discussed about, specifically like the cyst form or like the infective forms, so disease forms, which is asymptomatic intestinal infections, we're going to be using, like these drugs. I'm just listing out what to expect to look over. Like I don't want to go into too much details because you guys will be learning about it regardless. But this is just like a chart set up so you guys can just look over it, have like the drugs memorized, or at least familiarize yourself with the drugs and what classes of drugs. Because remember in the earlier drug lecture that I presented before, you had your classes of antibiotics as well as your antifungals and antivirals, and then also drugs treatment for your protozoans as well, right? So this just an example that I decided to post up, right, from like one of the slides of the form, how severe it is. From it ranges from asymptomatic to severe, and then also hepatic abscesses, right, leading to further complications and extraintestinal disease, right? Your azoles. I don't know if you guys remember the drugs that I mentioned with your azoles, right? Metronidazole and your tinidazole. Um, so those are like some of the drugs specifically that you guys can expect. So it is metronidazole. It is an antibiotic. And basically what it's doing is that metronidazole, it inhibits protein synthesis. So a lot of them is like, in order to stop the bug itself, you want to be able to stop the bug from existing. So one way that you could do it is to cut it down by interacting with its DNA and stopping the protein synthesis, and that's what the drug's purpose is going to be for. Okay, so this is just like one of the questions, is like basically what is the mechanism of action, right? Like they could ask you mechanism of action, clinical uses, right? Side effects of metronidazole, which again is just a protein synthesis inhibitor. It is an antibiotic, and it's one of your azoles. And from my understanding, if I remember correctly, the questions for farm were never like really that tricky. They were pretty straightforward in terms of like what to expect. Like if you know the mechanism of action, if you know the what's the side effect, like that's pretty much what they're gonna ask you anyways. So and your metronidazoles do come under your class. So you have your class of your your imadazoles. So azoles, remember, like the key way to kind of like look at it, also organize it, like I've mentioned before, organize it, find out ways to kind of memorize the drugs, because there's really, again, I can talk about this, but it really is all like really all you have to do with farm is just memorize it. But specifically for metronidazole, we're going to be using it also in H. pylori. We use that as in place of I'm not sure if I've mentioned H. pylori, but H. pylori is Helicobacter pylori is one of the few bacteria that you really, really have to know, because it does cause ulcers, right? It can cause ulcers, and then it does have specific virulence factors like CAD2 that you have to know. And then for that, it has several lines of treatment that you also have to be wary of, because it has you use like if this drug doesn't, if amoxicillin doesn't work, because they might be either like allergic to like penicillin or something, and you're using a triple therapy regime, meaning that you're using 3 drugs to treat the H. pylori, metronidazole is one of the alternatives that you can use. And so basically it's just stopping protein synthesis, and it's breaking down the DNA strands and eventually leading to cell death. And over here, pretty much the mechanism of action is listed, right? What it's doing, right? And how it's doing it, right? Metronidazole, it's reduced in obligate, right? Anaerobes, I've mentioned. Also categorizing, knowing what bacteria upcoming is an obligate anaerobe, as well as what is like an aerobe, as well as just knowing the different classes. It'll just make it'll make it so much easier for you guys to be able to just really be able to reel in and like kind of just cancel out all the other choices that don't fit in. So this is just basically, again, the mechanism of action, what it's doing, right? The nitric group of your metronidazole, it's reducing an anaerobic, right? Makes it sensitive to protozoans, like over here. And then what it's doing is it's interfering with its ATP generation. And I don't know if you guys recall from Med 1, ATP, in terms of like your electron transport system. ATP is like very important as part of that system. So we also have again, you guys can read this. I'm gonna post this up anyways. This is just all FNI. This goes kind of into details, but the professors will have something that they will highlight. So just look out for whatever is highlighted, and really focus on what they bold. Okay, and over here, clinical uses, again, for metronidazoles, right? First line of amoebic infections, and then for Giardia, which I mentioned, which is like if you guys remember, it's like the river, the one that you find in the water. It's pretty, and it gives you, Giardia gives you you know, like foul smelling stools, one of the ways, and then they can ask you treatments, metronidazole, you know, like what is it used for? It's like pretty straightforward. There's not really much to add. It's like, you know, like not, it's no like, you know, crazy concept to understand. It's pretty forward in that you have something, you have a drug, you know, you use it, what it's treated for. But over here again, listed it all out, you know, what specifically you can use these for. Anaerobic bacterial infections, you know, vaginitis, trichomonas, also learned this, and so forth. And then you have your, again, another one, pseudomembranous enterocolitis because of C. diff. We're also going to be using metronidazoles. You know, sometimes it's preferred vancomycin. I don't know if you guys remember if what vancomycin is, but basically vancomycin is part of your glycopeptides, something that I've listed in the previous pharm lecture. So vancomycin is it's part of your beta lactam antibiotics. So if you're, that's like another thing, if you know that if they're not responsive to a vancomycin, and they're right, then they'll ask you the alternatives. Okay, you can give them metronidazole. And then also, you know, these you can also use it for your gingivitis, trench mouth, and so forth, that Helicobacter, like I mentioned as well over here. And then here, like this is the most important things, the adverse effects when you're looking at pharm, right? We're seeing over here the adverse effect listed. Hold on, let me just get my pointer out. I don't think I have a pointer, but if you guys can see my mouse. But over here we have the adverse effect. And then see most common over here, like you will see something that really stands out the most, and that is that it gives you a metallic taste, right? Using it for too long can give you peripheral neuropathy. So that's something also to look out for when you're reading pharmacology and you're learning about like the side effects, what to keep in mind. And then high doses also, what can do in high doses, it can cause seizures, and it can also cause intolerance to alcohol, right? Because disulfiram, that's why they advise you not to use not to use benzos with alcohol. Same, you know, like same thing, high slower, you know, sometimes they might list, you know, the same thing, like something similar to the one drug, and they give you like a slight variation because it might be something like longer, but that's pretty much it. And then this is just basically like a question that they can ask you, explain, right? Just a simple question that they've that kind of like how to expect them to ask you something. Like I just wrote it out in general form. So this is just and you guys could just see it. Okay, so now you have your bendizoles, right? And these are specifically going to be used in your worms. So mechanism of action, same thing I've written out, that it's used for specifically for inhibiting your microtubule assembly. And then over here, you see that it's going to be binding onto your culture sensitive site of tubulin. So once it does that, right, what else is it doing? Like if you're understanding that, okay, it's stopping microtubule assembly, then you know that because of that, you're not having any glucose uptake. And they can sometimes throw a question where they could be like, okay, you know, decrease ATP and glucose uptake has also decreased. So they could kind of like question you on that, specifically about a drug, and not tell you the drug, but just tell you the mechanism of action. So also just be wary of that. So larvicidal and ovicidal just means killing the larva, right? And then this is just killing the ovum right here. That's what it's saying. It's killing the eggs versus the larva, and in what it's in, what protozoans it's, you know, like affecting. And then in the bottom we see that, you know, adverse effect, again, the adverse effect, it's reversible leukopenia, right? Can cause reversible leukopenia. So meaning you have you know, low amount of white blood cells, alopecia, which is basically hair loss, and then elevation of liver enzymes because it is also affecting your liver, and you'll have more on a blood test or on a similar on a test or a panel. It would show that your liver enzymes will be elevated. So okay, way to remember mostly for like for GI, just for the worms, like the azoles, most of them have the azoles, the bendizoles specifically for the worms. So it kind of makes it easier to remember, because if you know that it's bendizoles, like it'll help you kind of like understand, or kind of like just remember, not even understand, just remember which one you use for a worm. And same thing over here, mebendazoles, right? They're going to be selectively inhibit your microtubule synthesis. Drug of choices for your pinworms. Notice how like over here, I switched it up to pinworms and whipworms. And as opposed to the full name, they could also, like I mentioned before, as opposed to the full name, they can just ask you a question with the pinworm. They can be like, okay, what's a pinworm? I mean, if you don't remember what a pinworm is, or at least you know the full name of the drug, like Ascardis Lombardis, or like the full name, but you don't know if it's a pinworm or if it's a whipworm, then that's what's good to kind of know what the base layman term is for that worm. And they could just put it as simple. But also pinworm is also like refers to a group of worms as well. So pinworm itself could have several other pinworms with different names. So it's good to kind of classify it based off of, like I mentioned, classify pinworms with your roundworms and your, I think there's only one whipworm that we have to really even know. So don't even worry about that. But basically, also categorize them and know what type of worm it is. Right. Over here again, I listed out adverse effects, right? Because it causes GI irritation, because you are inhibiting your synthesis, and at high grades, it's going to cause your granulocytopenia, right? Penia is just like less, so alopecia, hair loss, so forth. And then this is just for the antiparasitic drugs. Pretty much just listed out where you would expect, the agent to affect the protozoan, like most antimalarial, right, inhibit, for instance, it would inhibit the DNA synthesis. So this is where it's going to target. So this is kind of like a good overview. Like if you're a visual person and you want to see where, like the drug is affecting the worm or the parasite you want to see. So this kind of shows you what it's doing. And if you like want to draw it out, also want to be able to see, like just basically want to be able to see like how it's working, and text does it. If text is like not your thing and you want to visualize it, this is like a good way to see what's affecting either like DNA synthesis is being affected, or is it like the protein synthesis versus like metabolism or microtubules and so forth. Just some questions that they can throw at you, like the importance of rehydration and diarrhea management. Like if you are giving it specifically for bacteria that do cause diarrhea, right? You want to like electrolyte, you want to like replace your electrolytes. What type of drugs, right? Common empiric drugs used in diarrhea, and then the actions of like fluoroquinolones, right? I don't know if you guys remember what your fluoroquinolones are, but basically what they do is that they, if I recall correctly, what they do is that they inhibit your DNA gyrase and topoisomerase, and that you guys do need to know from Med 1. Like you need to go back and know everything from this drug, know your gyrases, know your topoisomerases, know what supercoiling is. Like you have to review it. Like you have to know this. Like don't like waste your time. Not even waste your time. Like spend time now. Going over stuff from like Med 1, because Med 1 is extended, right? Med 1 material is just like Med 3 is just an extension of Med 3 is an extension of Med 1. So it's best to kind of go back and review Med 1 material, specifically review, your cells and your structures and all your, just basically knowing the the morphology of a cell and what the DNA and the RNA components of it, and as well as your protein components of it, and like what, like causes DNA formation, RNA synthesis, and all that stuff, all those little stuff. It's recommended that you guys like go over it. It just helps a lot with the drugs as well, and you won't get kind of like you won't stumble on a question if they ask you like it inhibits the gyrase or whatever, a drug that inhibits a gyrase or like inhibits topoisomerase, like it just makes it easier to understand like that. So these are some of for instance, going back to the first where we talked about bacteria specifically, we did talk about our, our bacteria that cause diarrhea, acute diarrhea. And what you want to do for it, how you would want to handle your acute diarrhea is just you're going to basically want to oral rehydrate, right? And then this is just something that you guys are going to be learning as well, like how to like I don't think they've asked about this question of like the half tablespoon. It's just for your information on how to treat. But again, what it's doing is that you want to use it to use the intestine sodium, the SGLT transporters. Again, you want to also be mindful of your transporters in the body. Like if you could know all the basic biochemistry from Med 1, like biochemistry does carry on. Again, it's going to make things much easier to traverse. Okay. And then this is just, management again, drugs that are managing for diarrhea and ETEC and EHAC. I don't remember if you guys recall ETEC, EHAC from the earlier session today. It's like you're going to be using your fluoroquinolones or your azithromycins and your rifaximins. And fluoroquinolones, again, right here, basically inhibits with DNA your mechanism of action, your clinical usage. So these are the ones for diarrhea, right? Caused by Shigella, Salmonella. These are the bacteria that we went over earlier. So caused by Shigella, Salmonella, and then Campylobacter. And sometimes they can ask you a question just on, a gram-negative bacteria, right? Or if you had like a gram-negative bacteria, if you had gram-positive bacteria, they won't even give you the name. They will, it's kind of like expect you to know, what you would use for like the gram-positive bacteria, given that it's a diarrhea. So it's important to kind of also write it out or have a chart out with your, especially like if you feel like it's going to be overwhelming to memorize everything and you're worried that, oh, how are we able to like know so much? That's why it's a good thing to get started now with just going over like the post that me, Alex, and like Kevin, like our slides that we posted, and going over through them because you guys are getting a great like overview and insight as to how, like what to expect. So that way it's not like something like, oh no, like I wasn't expecting this much, but now we're like we're telling you how much to kind of like know. Maybe they might change something in your syllabus later on, but this is like what we had to go through. So I'm assuming that it's not going to be that much of a change. Okay, so again, it's clinical uses, what we're using it for, fluoroquinolones, sketchy, and also sketchy for farm. I really highly recommend sketchy for farm, for micro. Honestly, that was a lifesaver. Again, recommended, right? And okay, over here, side effects. They could, you don't want to use it in pregnancy and in children. And then again, some of the ways, just wanted to like some of just an insight as to how they can ask you a question, right? Mechanism of action of vancomycin versus like, use of rifaximin, fidaxomin, and so forth. And this is for C. diff, right? Also, some of the things that they're going to emphasize, specifically some of the bacteria, are going to be more highly emphasized because it's more like spread and it has more of a clinical impact as opposed to other bacteria. So this one, I don't know if you guys recall from earlier, but pseudomembranous colitis, I mentioned that this is a kind of a buzzword because it's for C. diff, and Sketchy does a good job in helping you remember. So, for instance, C. diff, right? They give you this C. diff, right? It's disturbance of your normal, because some of them also, again, remember that some of the bacteria that I've mentioned and also listed, they are part of the normal flora in the human body. So, like you would expect to see them in the normal flora of the human body. So this, when they talk about normal colonic bacterial flora, um, that means that other bacteria are being affected by colonization of C. diff. And basically, you do see this, like if you've been pumped up with a lot of antibiotics, and C. diff is opportunistic, so C. diff can technically, just like colonize the bacterial flora and then cause, disturbance. So it will cause mucosal inflammation, and then toxins also, damage from the toxins. Again, another thing to know and remember are your toxins, what toxins they're producing, what toxins they're releasing. Some of the toxins are going to be more important to know. They might have a lot of toxins, but usually in like birth state and unlike Amboss or Sketchy, or like even the professor slides in the book, especially the book, if you're reading medical microbiology, they will list out like the most important toxins to know. And then symptoms, right? Moving on, symptoms, we talked about this, right? Watery diarrhea, right? Fever, so forth, how we can diagnose it, and then how are we going to manage it as well. And then we have vancomycin. Vancomycin is different from all the other penicillins in the fact that this is another thing, right? So penicillin, right? They can just ask you questions on, all right, so how is, they could just simply ask you that there's a drug that binds, that's diella muramyl pentapeptide, right? They could ask you about that drug also. So that's why it's bolded. So you guys know what to look out for, know what like stands out. And then like if you can remember what stands out, then like especially like if you're like studying last minute and you want to like and you feel like you're forgetting some things, best to kind of like pick up on what's the most different thing about it to help you remember, or at least like separate it from the rest. Resistances as well, right? You're going to learn about that. You're going to learn about resistances, and then also vancomycins, right? The uses for it. If you use it, it's usually given orally, right, for C. diff and for staphylococcus as well, enterocolitis, and it's used for serious MRSA. So MRSA stands for like methicillin resistant strep. So infections. So you would give vancomycin for that. And for enterocarditis, you guys are not really going to learn about endocarditis until Med 4. They're going to like really go hard, like harder on endocarditis on Med 4. But yeah, adverse effects over here, it's highly systematic, causes high systemic toxicity, Redmond syndrome. See, like when you're going over it, you will see things that stand out the most. So Redmond syndrome, autotoxicity, um, and are these drugs introduced? No. So these are not introduced. So okay, so so if you're asking about if I've mentioned these drugs in the foundations module, then yes, I do have them in the pharm module. I have all the antibiotics that you guys will be going over listed in that pharm PowerPoint, but also like I'm posting up this slide regardless as well. I'm going to be posting up this just to help with GI as well. But just in the foundations, you guys will be learning about like most of the antibiotics that you're going to be seeing carries on. So it's not like it's going to be something new because the bacteria might be the same. There's going to be some different bacteria that you're going to learn, and some different, protozoans, of course, are going to be new, but the bacterial that you're going to learn early on before GI. GI, I believe, might be the last. It might be the last, actually, it might be the last module for you guys. So you're going to be learning everything else pretty much beforehand. So you guys are going to be well exposed to the antibiotics before the GI module even comes. Again, rifaximin, right? Rifaximin over here, binding, how is it binding, right? Mechanism of actions. We're going to be using it in traveler's diarrhea. They can literally ask a question about person, came with came with like, came from a different country. So also, I know Alex mentioned, she mentioned about like how ICM is going to be different for you guys, and ICM and Med3 is also different because if you guys recall in your history taking, you guys do have to ask about if they've had any recent travel or not for a couple of things, right? And this could be one of the things if you do happen to have a patient that comes to you with complaints of diarrhea. And then one of the things that you want to know right away is like if they've traveled or not. And then again, other forms to know, fidaxomins and mycin, right? Mycin's same pretty much for your C. diff as well. And this might seem like a little bit overwhelming with all the bacteria, all of us, throwing it out on boot camp, but you guys are gonna have it spaced out throughout, and this is probably and you guys probably most likely will go over your macrolides and your azithromycins and all that stuff. You will go over your fluoroquinolones by then. So this shouldn't be as like, it shouldn't be as new, but now is the time to kind of like expose yourself to, so like, just categorize it. So when it comes time, when you're learning, check off the things that you're going over, and then list it. Like, I can't really emphasize enough of how important it is to have a list, to write it out, to, especially for micro and immuno and farm, because these are things that are new, that we didn't have to do much farm in Med 2, didn't have to do any of this, really. The bacteria, not much bacteria, but farm in that, you can kind of categorize it. Like I've mentioned before too, farm, have your bacteria, for micro, have your bacteria out, have write out your viruses, write out your bacterias, separate them, group them, and then, write the treatment for them. And then if you have that table up, then you guys are pretty much set for any question that comes from micro or from farm, right? Or, like, you guys are set. You guys don't, like, it'll make things a lot more smoother. Moving forward, right? This is just like a sample question, right, that they can ask you, right? Comes up, and like what following of the drugs, right, is most likely to be useful in treating her condition. Same, just a sample question that they, like an example of what she was diagnosed with, colitis, right? From staff most likely, and then she's having diarrhea, college students. Oh, another thing that I remembered was that there are certain diseases that are more, or sorry, certain bacteria that are more prevalent in dormitory type settings, like specifically Neisseria is like one of them, if I remember. And there are certain things, so they might ask you. Another thing to know would be like a college student. It's important to know that if they're like a college student, or if they're in the military or something like that, because it also helps you like kind of like categorize it in your head. Okay, if this is persons in a college or in a military or in some type of setting where you have a lot of students occupying like a small room or something like that, and it's important, like, if you know that, then you're able to kind of like narrow down your choices, and like more odds of choosing like the right answer choice. All right, so this is just for like IBD, right? Irritable bowel disease. I wanted to go over like some of the questions, right? The drugs that you would use. Again, these are just some of the questions written out. Just, what is a therapeutic approach? Like, as you mentioned, for Alex had mentioned about like IBD, right? how would we treat it, right? We would use aminosalicylates, right, for UC or Crohn's, and then corticosteroids and so forth. And these are just some of like the drugs that I've written out, that I've like posted from the IBD, right? It's from like GI. It's a mix of both path and micro, just to kind of put it all together, right? What we would use, sample way of like how they can cause this, because they could just, how they can ask it, fail to initiate therapy. So basically a patient's coming in, right? Patients with how you want to treat. If you guys can also like just have a real life scenario in your head, like, okay, like actually think that, all right, like a patient is coming to me, like how would I treat it in real life? Like what would I do? Because realistically, in less than, for you guys, in less than like a year and a half, or sorry, given a year and a half, whenever you take your test, like you will be doing this in real time. So it's best to kind of like now, like kind of like really envision that, oh, I know that I'm just studying for a test, but then this is just going to be real life later on, and this is going to be like, no, like I'm going to really be seeing real patients, and I really have to in real time diagnose them and try to approach your questions and try to approach the knowledge right now that you're learning as if you're really treating someone else, as if you're treating an actual patient. So that way it's like puts you on the spot too. It's like, oh no, like what if I had a patient right now? Like how would I treat them? How would I go about it? How would I approach it? Like what would I do? So if you can envision that in your head, it kind of like also makes things more interesting, and it kind of also puts you in the spot to kind of like, okay, like this is real, like this is going to be something that I'm going to be seeing in the upcoming time, and this is what I need to kind of like fix myself in and like really remember. And sometimes that can really help trigger like an emotional memory for someone, in terms of like emotional memories are just much more stronger than just a blank memory, just memorizing something, because you have an emotion attached to it. So it's you're able to memorize a lot stronger, or sorry, you're just to retain it a lot better, if anything. And this was just, just a kind of like something that to look forward, right? For IBD, right? Severe, like just the pyramids that you're going to be exposed to throughout the semester. You do have time, like Alex mentioned, you do have time, to kind of like, now's the time to kind of like over your break, leisurely, spend like an hour, like 2 hours, one and a half hours, like max, I think, just going over everything. Because, right now, really, you guys have like a month's time, and if you guys feel like, like you really want to excel, micropath, micro farm, you guys can get that right down. That's like easy points. Same thing, this is just from like the path forms I just mentioned. It's also in your in Alex's slides as well. And these was just your salicylic acids, right, for your IBD, listed out your mechanism of actions. What are they doing, right? Inhibiting synthesis. What are they interfering with? And what do they inhibit the activity of, right? Mention that as well. And then what are the uses? Crohn's disease for UC, and what how it can help. And then here's the adverse effect, right? 5-ASA, for 5-ASA, it's highly nephrotoxic and neurotoxicity. And then if you understand why it's nephrotoxic, right? Then like if you can remember the standing out portion, because I think I remember from like the slides, they did kind of bold it that it is nephrotoxic. So that was like easier to remember, because there was a bunch of things, nephrotoxic and like toxicity. Like if you know that that there's only certain drugs that really cause toxicities, it's easier to remember that. And just more questions, anti-TNF, right, for tumor necrosis factors. This is all IBD. Again, this is going to be posted, so you guys can feel free to go over, given I don't have much time left. These are all going to be posted up so for you. And then here are drugs that we talked about. Hepatitis, or drug classes, right? What it's targeting, since it's a virus, you want to target, if it's a viral factor, so you want to target, for instance, for drugs that listed over here, anti-caviar and then tenofovir, right? It's targeting your transcriptases, and what are they doing? It's like they're inhibiting your formation of DNA copy of a viral RNA. And then interferon, you have your drug classes, like I mentioned, nucleosides and nucleotide reverse transcriptase inhibitors versus your interferon alpha, right? JAK-STAT signaling, again, this is all biochemistry. Know your biochemistry, familiarize yourself with biochemistry. It just makes it easier to, like remember stuff, or at least remember, like the small little things, like what is like JAK-STAT signaling pathways in your T cells and so forth. It helps in, it really helps to know if you have solid biochemistry, it really does make things easier. Again, this is also for your hepatitis, your interferons, how it's affecting it, and so forth. And then we're just gonna, antivirals, same things. This one was a good way to remember. I remember your antivirals that we had. Your Previrs, right? Notice the drug names, and most of them will have kind of like the same suffix, right? Your Previrs over here, or sometimes they might have a similar prefix, but suffix is mostly their Previrs, right? Previrs, targeting your 3,4-A protease inhibitors. Okay, you know that Previrs are only, like they are specific for your 3,4-A protease inhibitors. And then if you know that, if you remember it, the Previrs, and you know that they're going to be, sometimes just make like a good mnemonic, or make a good correlation in how and what they're inhibiting, what they are targeting, and so forth. So again, this is all going to be listed. I'm going to have all of this listed out. Sample question of how they can ask you things. And then, yeah, these are same thing. These just, what its uses for breast cancer, this is more for like cancers and stuff. I believe you guys will have to know Chemoman. I think I might post that. It's like a whole list of drugs, like cancer drugs. Chemoman. I'm not sure if Kevin has covered that or not, but Chemoman is basically like, if you guys know most of your Chemoman really helps to kind of envision what drugs will affect where, what causes, what adverse effects they have. So that really helps in like narrowing down your farm, and easier way to remember things. But again, nothing really more for me to really expand on, other than, it's really a reading on thing, like understanding like the mechanism, the actions, the uses. The formula is pretty straightforward. MOA, right? Uses and adverse effects, and so forth. And yeah, that's pretty much it for this module. I will, I will be posting this up. And does anyone have any questions? Oh, Kevin posted up his link on the chat for his 5 to 8 p.m. session.
Please log out from this link completely, and then re-log in at the 5 o'clock Eastern Standard Time. Okay.
Yes, so perfect. So Alex has posted up a picture of the Chemoman, said Chemoman. If you know this Chemoman, like it's like draw it out. It really comes in handy to know what type of toxicities it causes. But other than that, if you guys have any questions, please do let me know. Anything you want to add? Other than that, so slide deck, the foundation drugs we need to know. Slide deck wouldn't Charmaine, what do you mean by which slide deck has the foundation drugs? You mean for antibiotics and antifungals, or are you talking about just specifically for the foundations module? So you guys will, okay, so you guys will be getting a syllabus, and the syllabus should list out all your drugs that you will need for that module, but I will post it up. I'll send it to you. Let me post it up from the syllabus, and I'll post it and I'll send it out to you. I'll post it up in the main chat for the immunomicro BC for Med 3 chat. In case you
Thanks,
don't find it.
The reason why I'm asking, I don't know about you guys, but sometimes I need to get a head start, especially because there's so many drugs. So being able to just kind of start going through them now, for me is going to be a big help. And I appreciate what you guys are doing right now. I really do.
Okay, yeah, definitely. Yes, if it's not, if so, okay, so for foundations, the drugs that I list, most of the drugs, the antibiotics, but if you're asking only specifically for foundations, then yeah, let me separate that for you, and I'll put it in the main chat. So that way everyone can like see it specifically just from foundations. I'll separate that out just for foundations. So if you want to look at foundations, at least you have a list. I can do that. I can put out the list and put it in the main chat. All right. Anyone else have any questions, comments?
I have a quick question, or I just want to like verify. So for you guys, in your opinion, for us going into Med 3, you recommend us reviewing foundations, just like the core concepts and foundations first, and then going and hitting like micro, pathoma, and then the farm in that order?
Okay, so because the thing is like you guys will be covering foundations. So the first module that you guys are gonna have in Med 3 is gonna be foundations, and that's a continuation of Foundations 1. So I just recommend going over foundations from Med 1, like at least just brushing up on foundations, knowing your um at least covering your biochemistry portion and all that stuff, right? And then I recommend going over the basics of at least the basics of microbiome and immunology in terms of knowing your immune system and your T cells, B cells, right? Knowing your pathways, alternative classic pathways, and so forth, and then knowing your gram positive, gram negative, knowing the structure of a cell. Like if you break it down, I would say just go over some of the biochemistry. It doesn't have to be too hard because you guys will be going over it in details as well throughout the semester, but just to brush up, I would suggest go over med 1 material, just glance over med 1 material, see whatever you guys were weak at or weren't the best with, because honestly, like for me, foundations wasn't the greatest just because it was all over the place and biochemistry was not the best for me. So I had to like revisit foundations, and then yes, go over some of the foundations, and then if you want, you can go over. I would say do farm last because you need to know what you're studying the drugs for, right? Like if you know what like you don't want to do farm before you want to do the actual micro, like the bacterias or the virals or the fungus, because it just makes it easier. Like if you do the microbiome first and then you put the treatment, which is the farm, later, then it just helps things better with the flow. But if Alex or Kevin wants to input, please feel free, Kevin or Alex.
Yeah, but I would rather spend the more time for like new materials that are including the slides that we sent you, rather than like going over every details of the Med One stuff. Because you Med One stuff that you definitely need that sometimes the information from Med One, but it's not really kind of repeating the same thing in Med Three. Okay, so probably going forward more to the like preview, spending more time in preview rather than reviewing the Med One very thoroughly. Okay.
Thank you.
Yeah, I think so too. Like the Med 1 content would be more refreshed, like you will refresh it better in context with the new material, like with the diseases. But definitely agree with Sunny as well to review all you remember the GQ, GS, all of those pathways. And it's like I remember in Med 1, it was like so overwhelming for me to memorize. But once you look, like if you just look at it right now, in context of the disease, that would be very, very easy for you to remember. Yeah, I think first aid would be kind of like your go-to materials to review for Med 1.
Thank you.
You're welcome. Yes, I agree with Alex on that. Definitely first aid. First aid is like a great refresher for your biochemistry, because you could just like skim over to the biochemistry part of first aid and then review that, and that should, like be very helpful in at least brushing out your foundations, if anything, as opposed to spending way too much time on Med 1 and Med 1 material. But because the focus is going to be also now newer with Med 3 and with more of an immuno and path and micro portion. So yeah, first aid it would be like definitely a good refresher as well. All right. If that's all, then thank you guys for joining us. Guys, Kevin will be having his session at 5 p.m. and he did post up the link. So see Kevin at 5 p.m. And thank you guys for coming.
Yeah, please log out completely from this chat, and then from this the meeting, and then the relog it from the new link that I sent you at 5 o'clock. Okay. All right. See you at 5.